So today I'm going to discuss about the management of C-shaped canals. It is considered to be a tricky anatomy. Reason: in our routine clinical practice, we face certain clinical challenges during root canal treatment, and these challenges includes management of severely curved canals, management of S-shaped canals, management of radix entomolaris, management of dense invaginatus. So C-shaped canals are also included in those challenges. So here I am going to discuss about its nomenclature, its prevalence, its diagnostic challenges, and its management. So very first, why they are so called? They are so called and they are so named because of the cross-sectional morphology of their fused roots and the root canals, and its pulp chamber of molar with C-shaped root canal system is single ribbon shaped. मतलब ये कि जब भी आप सी शेप रूट कैनाल वाले केसेस को देखेंगे मैनेज करेंगे तो रेडियोग्राफिकली आप देखिएगा उनकी जो रूट्स होती हैं वो बिल्कुल फ्यूज्ड होती हैं, उनकी कैनाल्स फ्यूज्ड होते हैं. यू कैन नॉट डिस्टिंग्विश बिटवीन द पल्प चैम्बर ऑफ दैट सी शेप कैनाल सिस्टम. सेकेंड जी, उनका जो पल्प चैम्बर होता है, जो एक्सेस ओपनिंग के बाद जो पर्टिकुलर शेप होती है, ट्राइंगुलर, रेक्टेंगुलर, रोम्बोइडल, उस तरह नहीं होती. सिंगल रिबन शेप्ड ऑरिफिस सिस्टम होता है इनका विद जो 180 डिग्री की के एंगल पे. तो नाउ इट्स प्रिवेलेंस, ये कहाँ कॉमनली आप सी शेप रूट कैनाल्स को ऑब्जर्व कर सकते हैं? मैंडिबुलर सेकंड मोलर में, उसके बाद मैंडिबुलर फर्स्ट मोलर, देन फॉलोड बाय मैक्सिलरी फर्स्ट एंड सेकंड मोलर, लास्ट मैंडिबुलर फर्स्ट प्रीमोलर. So, what is the main cause for its development? The main cause for the development of C-shaped root canal system is failure of heart-weak epithelial root sheet on either the buccal or lingual root surface. Now come to its diagnosis. फॉर एग्जाम्पल आपने जो है एक्सेस ओपनिंग की है, एक्सेस ओपनिंग में आपने देखा है कि you have found certain a groove present on the lingual or buccal surface. It gives you an idea of C-shaped canal system कि भाई यहाँ C-shaped canal हो सकता है. ठीक है, ये एक क्लिनिकल साइन है इसकी. अगर इसको हम रेडियोग्राफिकली देखें, क्योंकि जाहिर बात है प्री ऑपरेटिवली रेडियोग्राफ देखें, और प्री ऑपरेटिव रेडियोग्राफ हमारी रूटीन प्रैक्टिस में 2 डायमेंशनल होते हैं, तो हमें वो फीचर्स पता होने चाहिए. अगर हमारे पास सीबीसीटी अवेलेबल नहीं है तो 2 डायमेंशनल रेडियोग्राफ पे ऐसे कौन से फीचर्स हैं जिसके बेसिस पे आप बताएंगे कि इसकी जो है सी शेप रूट कैनाल सिस्टम है इसमें. तो वो फीचर्स कौन से हैं? इट इज़ वेरी डिफिकल्ट टू डायग्नोस सी शेप रूट कैनाल बेस्ड ऑन 2 डायमेंशनल रेडियोग्राफ, but in some cases particular radiographical finding can give you a clinical suspicion of C-shaped canal system, and these include very first fused roots. एक तो फ्यूज रूट्स होंगी. सेकंड, यू कैन नॉट पुअरली डिस्टिंग्विश फ्लोर ऑफ द पल्प. आपको पल्प चैम्बर का फ्लोर जो है वो रेडियोग्राफ पे आप डिस्टिंग्विश नहीं कर पाएंगे. थर्ड चीज जो है, जब भी आप वर्किंग लेंथ के लिए रेडियोग्राफ लेंगे ऐसा लगेगा कि आपने परफोरेशन कर ली. इट गिव्स अ फॉल्स इंप्रेशन ऑफ परफोरेशन इन द फर्कल एरिया. और चौथी जो चीज है, जो भी आप वर्किंग लेंथ के इंस्ट्रूमेंट्स लें यूज करेंगे वो ऐसा वो जाके नीचे जाके कन्वर्ज करेगा एट द रूट एपेक्स. Now look at this picture. This is a case which is showing the poorly distinguished pulp chamber floor with convergence of instrument at the root apex. So now this is a CBCT finding. On CBCT finding with red arrow showing C-shaped canal system in bilateral C-shaped canal system on axial view. You will find C-shaped canals on the axial view. So this is the classification. C-shaped canal. This is the most common anatomical classification you will follow to classify C-shaped system, C-shaped root canal system. Very first, uh, C1. The shape is uninterrupted, no separation, no division, continuous C-shaped canal without any interruption. If you find any discontinuation, interruption, then will be classified as a C2 shaped. Now C3, 2 or 3 separate canals are present, and C4, single canals, and C5, no canal lumen can be observed, which is usually seen near the apex only. Now this is known as 3 dimensional classification of C-shaped canal configuration. This is known as merging type, means A canal shows a bulge at the center towards the root apex. Now this is symmetrical. Canal is bifurcated with mesial and distal. This is known as asymmetrical, with one canal is comparatively very thin. Now let's discuss about this case. Now this is the clinical picture of C. You are showing you are observing a C-shaped canal system, mandibular second molar. What it shows? It shows a semicolon pulp chamber, and you will classify this as a continuous C-shaped canal system with the deep groove present on the lingual surface. This is the clinical sign of C-shaped canals, and anatomical classification is C1 of this case. Now again, this is the radiographic sign of the C-shaped canal system. During taking working length of this case, it shows convergence of instruments at the apex. Again, this is the radiograph related to obturation of this case. All GPs are converging at the apex. So this is the simple introduction of C-shaped canals, right, starting from its nomenclature to its diagnostic challenges. Now, management of C-shaped canals. Protocol for the management of such cases. You very first requirement of for the management of such cases, you must use magnifying loops, microscopes, CBCT to aid in better understanding the canal system. Why? Because in without these system, there is chances of strep proper perforation during the management of such cases. So this is a first requirement to manage such cases. And you find canals, then you must explore the canal with small size files, 10 8 10 15, so as not to miss irregularities. You use self-adjusting files. They are considered to be efficacious in cleaning and shaping the C-shaped canals, because these files have the capacity to adopt the canal shape. Now, filing motion, circumferential filing should be done to ensure maximum tissue removal. You follow ultrasonic irrigation. You must not follow traditional methods of irrigation, because they cannot properly clean the irregularities present inside this system. Followed by obturation. How will you follow the such cases? Ideal method of obturation, and in these cases, is thermoplasticized technique, thermoplasticized obturation technique. Now, this is a case report of C-shaped canals, intentional replantation of C-shaped mandibular second premolar with radicular groove. ये case report है journal, it is has been taken from the Journal of Endodontics, July 2025. So, how to manage such cases? Intentional replantation. Now, this is a clinical case. Now, this case is related to a 31-year-old patient. So basically, he presented with complaint of gum swelling related to the mandibular second premolar. This is the clinical radiograph of the periapical radiograph of the related, showing mandibular left second premolar, mandibular first molar, and mandibular second molar. So he complained of gum swelling related to tooth which was endodontically treated and crown. This radiographical picture is also showing uh, root canal treated along with PFM crown. So clinical examination revealed a lingually located sinus tract and clinically intact porcelain fused to metal crown. Tooth was not tender to percussion or palpation. There was no any pathological. These are the investigations of this case. Now, investigations showed that the tooth was not tender to percussion or palpation. There was no any pathological probing, and periapical radiograph with gutta-percha point position in the lingual sinus tract traced the sinus tract to the mid-third of the root, which otherwise had adequate root canal filling and intact periodontal ligament in the apical region. Now, this case report usually shows that patient came to OPT with presenting complaint of pain. All investigations showed that radiographical examination showed well condensed obturation with intact ground with normal mobility, but clinically there was a sinus. Now, GP tracing showed that this sinus was related. Source of this sinus was related to the uh, to mid third root of the mandibular second molar due to the presence of a groove. Apart from this, B and C is showing the CBCT finding. What it shows? CBCT findings. Now this is the axial view. What it is showing? Now CBCT axial section of CBT showed the radiolation C at the middle third region on the lingual aspect related to the radicular groove of the C-shaped premolar. This is the radiolation C at the mid third root surface. Means now, despite of adequate root canal treatment and intact crown, there is a radiolation C that was detected at the level of mid third root, and was detected during CBCT examination. So how will you manage this case? रूट कैनाल भी सही है इसकी, पीएफएम क्राउन भी इंटैक्ट है, लेकिन जब सीबीसीटी में हमने देखा है कि वहाँ पे हमें एक जो रीज़न है, जो परसिस्टेंस पेन की या साइनस की, वो रीज़न जो इस केस में हमें जो डायग्नोस की है, दैट इज नोन एज रेडिकुलर ग्रूव. नाउ व्हाट डू यू मीन बाय रेडिकुलर ग्रूव? Grooves basically in teeth are developmental depression. They are present on the root surface, and they have been reported to be presented frequently on the proximal and lingual areas of mandibular premolars. These radicular grooves contains separate communication, the accessory canals. They maintain separate communication with external environment. With traditional method of root canal, these grooves along with accessory canals are difficult to be cleaned. So basically the usual cause of failure of root canal treatment in this case was radicular groove present on the mid third of the root surface of mandibular second premolar. Now question arises, how will you manage this case? This case was managed by intentional replantation. Why not surgical? Because surgical intentional replantation इसमें क्यों की गई है भाई? सिंपल रीजन है. व्हाट्स द रीजन? इंटेंशनल रिप्लांटेशन का कॉन्सेप्ट ये है कि आप जो भी टूथ होता है उसको यू एक्सट्रैक्ट एट्रोमेटिकली, then you perform root and resection followed by sealing, and then reinsert that suspected tooth into the same socket. So this case report basically emphasized the challenges in treating mandibular premolar with radicular groove that contain bacteria. So when the bacteria in these radicular groove leads to periradicular infection, then intentional replantation may offer a viable treatment option to address the clinical issue. This is the summary of this case report taken from the Journal of Endodontics. Many practitioners consider intentional replantation is a last resort for saving a tooth, preferring alternatives like non-surgical retreatment or conventional endodontic microsurgery due to possible damage to periodontal attachment apparatus. क्या होता है कि भाई जब भी इस तरह के केसेस फेल होते हैं तो हम वहाँ पे नॉन सर्जिकल रीट्रीटमेंट करते हैं. नॉन सर्जिकल रीट्रीटमेंट इसमें इसलिए नहीं किया क्योंकि बेसिकली क्राउन लगा हुआ है, वेल इंटैक्ट क्राउन है. दूसरा जो रूट केनाल है वो सेटिस्फैक्ट्री है. अगर हम नॉन सर्जिकल रीट्रीटमेंट की तरफ जाएंगे देन वी विल leads to the loss of integrity of tooth structure. We will further damage that tooth structure. So it is not conservative option in this case. So here in this case intentional replantation has been selected as a treatment option. That's it. So with this we came to the end of this tricky case, and